Okay.
So this was at a request of a few people who actually aren't here tonight. You know who you are. The first 5 minutes, so I kind of put this together. This is a similar session I did with my EMR groups, but this is really focused on, well, just what it says, that you're going direct, you're first on scene. You walk into a patient, it's 5 minutes of just you and scene, or you and a patient. So I am gonna nerd out a little bit, especially when we get into vitals, digging into why, why it's important and what little subtle changes could indicate. So I always say patient care starts before the call. This is definitely, when we get into, kind of skip down to the local knowledge and maps, you guys, for the most part, know this area better than I ever will. I'm trying to learn quickly, and as you can hear from dispatch, we are, from call to call, kind of adjusting the maps, figuring out who can get there quicker, especially when we look at kind of at the pinch points, like in Presque Isle up on B, we've been kind of shifting it. I think Annabelle Lake Road, maybe, I think is the cutoff from 9192. Put it this way, I know in 91, the Winchester crew can get to Big Horsehead quicker than Boulder. So we've shifted that line to the east a little bit. Down on the southern end of the district in the Boulder, Manny area corridor, we've been kind of working on shifting that. Crews have been really good, especially if they know the area, that they'll just get on the radio and say, that's gonna be 92s, we're taking that. And that's, for me, as long as I got a crew going. For the first time in my life, we had a call in Boulder. 9-1 was there, restocking. 9-2 was up in the PI, I think. And I actually had 2 ambulances kind of fighting over who's getting a patient. I never in my life thought I'd have that problem.
Julie and Jim just wanted to get out of the parade and we were there.
Exactly.
We worked collaboratively, we weren't fighting.
So if you have your kits here, here's something that I even have to do frequently. Like I'm probably the worst one to climb into any of these ambulances or the kit, because I'm just behind a computer. But knowing where the stuff is, I know when I was running as a first responder in my town I lived in previously, I would be driving to the call and thinking, okay, well, where is my tourniquet in that bag? Which pouch? So, taking that time, that even once a month, kind of going through your bag, kind of knowing where everything is. I'm really a minimalist when I carry my first responder equipment. I started with this big bag of everything from burn blankets and trauma dressings. I'll tell you, in my almost 30 years, I think I've used a burn dressing once, or burn blanket. So that gets lost. Kind of narrow it down to lightweight, move quick, and where I can easily find stuff. But know where the stuff is. Keep up on your expiration dates. With kits, especially medication, you've got to keep your kits stored somewhere reasonable. We can't leave them in the trunk of our car all January, February, and expect our epinephrine to still be effective. If that makes sense. So just keeping up on those medications and knowing those dates, and if getting a hold of your service director and or me if you need help restocking those.
So you're gonna supply us when I need new meds?
Yeah, so we've got, number one, the 2 reserve ambulances. We have a BLS med kit. I gotta get some nicer like pack-a-box to organize a little bit, but I think we have albuterol, Atrovent, I conceded, and we did put a milligram of glucagon in there. Don't know if we have any EpiPens, but we are transitioning to I think we've just been buying the drop Epi kits, that everything kind of comes together. I don't know if we have any EpiPens. And Narcan, intranasal Narcan. And I'm going to talk about Narcan a little bit deeper as specifically as one. Am I forgetting a med?
Maybe you're researching on the new Epi nasal. Kind of looks like the
Is that
Narcan.
the Epi nasal? I've seen the glucagon nasal.
It's an Epi nasal. It's supposed to. I thought it was supposed to be for
No,
allergic reactions. Yeah.
I will.
I saw some advertised on TV. I thought.
and I know this is more for the medics, but we just got approved and we're moving into the next phase. So I'm anticipating January 1 for the year of 2026, we are gonna be in a joint with at least 9 other paramedic services. We're gonna be trialing nebulized ketamine for pain control. We're working with the Medical College of Wisconsin and getting a researcher. And so I have pretty high hopes for that, for pain control, especially in pain diabetes. Okay, well, so knowing where your stuff is, the dispatch comes in, is, what's the nature of call? I got it out there, this is a medical call, trauma call. I mean, you guys are still getting called for lines down, carbon monoxide alarms. There's all different types of 911 calls we can do. And that's gonna kind of gauge how we're gonna respond, what equipment we're gonna grab. Staging versus direct. So this is something I've been trying to get a little bit better of a partnership with the sheriff's department. It's gonna take some time. They gotta get comfortable with me. Currently, right now, it's happened a few times where we're getting staged. Or they weren't paging the specific EMR group, they just paged the ambulance and had a stage. Now, I have told dispatch that that's not acceptable to me, that we still want the departments paged, that's their jurisdiction. We just need to coordinate on the radio and please don't go direct. They're staging us, and hopefully to kind of break through this, it's gonna be baby steps, but if you're told to stage, we're just gonna pick a location and you and the ambulance stage safely, a mile away is appropriate, depending on the type of call. So these are things we'll continue to grow with the sheriff's department, and hopefully we limit a lot of the staging. Otherwise, I think for the most part, you guys are mostly just going direct. And has that been working pretty good? Have you noticed any equipment needs or things you get to a call and you're thinking, gosh, I wish I had this? Patient bias. I would be remiss if I didn't talk about that, because I am just as guilty about this. I think everybody hears an address and right away you're like, never. And the patient bias, the trouble we can get in with that is essentially a form of complacency, that routine caller who calls all the time at really bad hours, let's just say if they're a pain in the rump, they can still be severely sick, ill, injured. And every time they call, they need appropriate assessments. Of recent, and paramedics in the back of the room that was on the call, we had a significant capacity concern. So who knows what capacity is? So has anyone ever heard the term, is a patient competent? So first off, just terminology, EMS or law enforcement cannot determine if a person is competent. A court determines a person's competent. What we look for is, does a patient have capacity? And that means, do they have the capacity to understand what were the medical risk of a refusal? Would that be appropriate, Katie? And I lean on Katie because she's kind of an expert in this field. So how do we determine if a patient has capacity? Katie, what are some?
So you're gonna wanna run through your mending mental status exam, right? Do they know what today is? Do they know who they are, where they are? Do they know current year? Are they able to answer questions appropriately? A thing that I use frequently is, I'm gonna give you 3 words to remember, and in a couple minutes I'm gonna ask you that. And so I'll be like, I want you to remember black dog house. I have a black dog in a house, so that's one that I go to frequently. And then in a couple minutes after I've been talking to them, I'll be like, what were those 3 words that I asked you to remember? And if they can't remember those 3 words, that demonstrates that there's impairment in their short-term memory. You're looking at, do they have hallucinations or delusions, in the case that he's talking about. The individual was expressing that they were seeing little men running around the house, and that they were hiding in places that were, one was a paper bag and one was a basket, so it wasn't appropriate. They couldn't tell me what year it was. They thought the president was still Obama. And so it's asking kind of those questions to determine, are they aware of who they are, what's going on, and do they understand and can they explain back to me what I just explained to them, right? So if I'm gonna let somebody refuse to go to the hospital, I need them to know that if they refuse, right? If somebody's having a heart attack and I can look on our monitor and be like, you are having a STEMI right now, and if you don't go with me, there's a really, really good chance you're gonna die. They need to be able to explain to me that them signing that form means they are accepting responsibility that they're gonna die, and I need to make sure they understand that well if I'm gonna leave them there. Those are
So really the issue we run into is, you know, the patient can't display capacity, they really can't sign a refusal. Which then it really turns into more of a law enforcement issue, and then the issue is what happens when law enforcement doesn't want to sign. And that was kind of an issue we ran into, and our crew handled it appropriately. They were able to, I think the resolution was,
a family member came and signed for the patient and was willing to stay with the patient because the patient agreed to go to the hospital later, but wasn't going to unless a different family member was there. And so there was an ex-wife came and said, yep, I'm accepting responsibility, I understand everything, I will stay with this patient in case anything happens, I'll call you back or take him to the hospital.
so even on lift assist calls, where you're going direct, I mean, it's allowable in our guidelines for an EMR to go assist the patient up safely. And if you feel that, or you've determined them to have good enough capacity that you can cancel the ambulance and use your services refusal form. And I know some of the agencies, we gotta tweak up their refusal forms for the groups, but whenever you're in doubt, just keep the ambulance coming. I don't think any ambulance is gonna get mad if you turn them around, if you get them up and there's no need, but, you know, within the individual agency, you keep that on your file, and pending, I mean, unless the patient refuses, you should at minimum have a complete set of vital signs associated with the refusal. Additional resources, you know, I don't know what the policy was before I got here, but any of the 4 agencies, if you feel a need to get additional resources, we're gonna need this piece of equipment from our fire department. I've been to this address before, we should probably make sure law enforcement is en route. If the ambulance hasn't done it, and you feel, hey, I know this intersection, it's usually bad, let's get a helicopter launched, that's all okay. There's nothing that says our EMS staff has to do it, that the jurisdictional department has that total authority based on your local knowledge. Now, may there be times the ambulance gets there and determines that flight's unnecessary and we cancel the helicopter? Sure. But that, you know, we don't, it doesn't mean you did anything wrong by getting them launched.
Can I go back to your capacity question one more time too? Alcohol is another issue. If they're under the influence of alcohol or drugs, that capacity question is pretty limited, and you have to use your best judgment, right? Because if you're below 0.08, you are not intoxicated, nor are you necessarily incapacitated. However, I'm sure you all have seen somebody who's a 0.06 and they can barely stand and they're tripping over themselves because they can't handle their alcohol, and that would be incapacitation for that individual, and so they would not have capacity in that moment. So that's another thing that you want to pay attention to with capacity and competency as well. Is, are they intoxicated or under the influence of drugs or alcohol?
And those, for me, are the toughest calls. But, you know, to prevent, I guess, you know, we do have to think about liability, not only you, but the town you serve. That we need to go through these steps. I know it's even the rump, but a lot of these people move them to the next level of some type of avenue with the social services in the county. You know, there needs to be documentation of that. So we're just going and checking a box every time. And after the 15th time, you know, we get a referral, and they'll be like, well, where's your documentation? Your start point. So that, you know, the first time we start getting these, you know, just good, clear documentation is not only good for protecting your and our liability, it's also what's right for the patient and making sure that we get them the resources they need going down.
Can I ask another question quick, Jason?
Yeah.
On the stage versus direct point, I've never heard that, I haven't been doing this too long, but With Viles County page, hey, first responders need to stage here, along with ambulance?
Well, that's usually what, a lot of times they might, well, my experience, they did stage us at, I think the last time was Prescott Fire. So they just said stage there, they gave us a location. Otherwise, local knowledge, if you don't have a location, you can ask dispatch, you know, hey, we acknowledge we're en route, where's the staging location?
They not always know. The most important part of staging is out of sight. You don't wanna be near it. We had an incident that they parked near the incident, the guy comes running out of the house, we're done. They were luckily in a position they could go forward and move, get out of there. They were just waiting for the cops to get there and felt, oh, we're parked in front of the guy's house.
Yeah, not the,
Staging's out of sight, that's the big thing.
Yeah, there might be times where we can't stage together too.
Right, you're
So
coming from
You
opposite
guys are
directions.
over here,
Yeah.
and it's kind of best judgment knowing the area.
Yeah.
Just stay away from seeing until,
and just communicate on the radio, nothing needs to be secretive or using codes on the radio, just say we're staging at.
But like, Porky's case, you don't know if the guy has a gun, he was just listed as a call, right? You go direct.
Maybe, so I will get into that, if they didn't stage you, so you have a lit assist at whatever address. And you go in, and anything seems out of whack or threatening, you leave. You know, if you feel a threat to yourself, and I'm not talking of just death, but even injury, just leave. If you feel unsafe, just leave. And you walk out, you get on your radio, Vilas, we need law enforcement emergent. And that's it, just get out of it, drive away. You know, that's good to know, because, you know, when we talk about that initial size up,
Izzy and prednisone is not doing good. Don't mind me.
Yes, so, just, and fortunately, you know, we don't see a lot of that here. But I can speak, I personally, even on an ambulance crew, we see a lot. This guy's crazy, I fear for my life, he's leaving, you can keep bleeding, cops come here, and when they get scared. And if it's a threat that's not patient banned, that you're just taking care of safety. So, scene assessment, we'll dig into this just a little bit. I'm trying to, you know, skip over, you know, a lot of times we just take this stuff for granted. So, everyone remembers we took school, BSI, scene safe, blah, blah, blah. So, BSI, scene safe, digging in, I always say appropriate BSI. And I'm probably the worst person to teach this. You know, do we need to be gowned up with you know, respirator masks and, you know, full face shields and PAPRs and all that? No, that does not need to be in the case. What I strongly recommend is at minimum gloves, protective eyewear for patient care. And just, you know, the good, you know, I have to do down the range, I'll post it, and I have to do an annual BSI class. Probably do that in January, which I know no one will show up for. But you'll tell me you watch the video. You know, we're required by administrative rule to do that, but, you know, just appropriate BSI. And more, also with that, appropriate PPE. You know, we shouldn't be showing up to motor vehicle accidents in sandals and shorts. You know, we don't want you to be at any risk. No, it's not, no accident is worth your injury. 360, I put that up, you know, when we're looking at things like motor vehicle accidents or fires. We gotta start outward and go inward, that even if we can see a victim, it's a dangerous environment, there's multiple layers of things that could be unsafe, that you really need to go around that entire scene to look for hazards. And when we take, let's just take a car up in someone's yard, up against a tree. Damage is moderate. Got any of those underground transformer things up here?
Yep.
You know how much juice is in those things? So if that car is energized and we touch that car, power lines is always something that scares me. Do you smell gas? And what can be a simple medical call can be a quick cop on the radio, we need fire department use page now. And let the fire department do that. And I know a lot of you are cross-staffed, and I'm just coming from the EMS perspective. But our job is proper assessment, management, treatment, and transportation of a patient. Not, the district doesn't, we don't do the firefighters. Threatening patients, we had just kind of talked about that with you briefly, is, if a patient starts to be altered to the point of they're making you nervous, or I think we recently had a call where there was a rifle against the wall. Even asking, like, getting law enforcement there, or just say, hey, I gotta go to my car, get a piece of equipment, I'll be right back, and then don't come back. Just get in and drive down the road, say, we need law enforcement here. Emergent. And I think that's one thing we had to do in my previous department, is we have to specify we need you emergent. Otherwise, I don't know what it's like up here, but where I came from, we just said we need law enforcement. They drag their feet and hoping we just take care of it before they get there. So make sure we use that word, we need you here fast, emergent. Overdose patients, unfortunately, this is an area that I had way too much experience. And I'm sure everyone heard what happened in Appleton. Gosh, what was
My
that?
partner,
Several years ago now.
Crispies.
Overdose patient, they woke him up, they're talking to him, and some trigger, long story short, took out a gun and he killed a firefighter, Appleton firefighter. What's it?
It was Mitch Lundgaard, and Crispies was the cop.
Yeah. I've been to overdoses where they've been in their whitey tighties underwear, and we Narcan them and wake them up. And while he's sitting there kind of coming out of it, he reaches into the back of his underwear and pulls out a knife that he had in his butt crack. He looked at the knife and then set it down, but what would have stopped him from, if he'd have made one swipe, he'd have caught three of us that were standing next to him. So I learned with a lot of those overdoses that, in fact, I gotta mark that down, we gotta get those turtle skin gloves, keep in our bag just in case. But really, it's not EMS's job to search people. I wouldn't recommend searching suspected overdose with just latex or nitrile gloves. A lot of pointy things that unconscious people might have them on, and we don't want to stick ourselves. So we kept the turtle skin, which is puncture resistant. You can still get poked with them, but not as likely. But long story short, nobody gets Narcan until we search the person and their immediate surroundings, which I've kind of gone back and forth with law enforcement on, where, well, we can't search if we don't have a warrant. I'm like, look, I don't need you to check the room. I need you to check under the pillow and the bedding that he's laying on to make sure there's not a weapon. For all of our safety. And we'll just bag him. And then once we've determined, basically make him naked, he doesn't have a weapon, or two.
It's really good eye gel practice time, you guys.
Then we give the Narcan. But I guess with having treated enough overdoses, this is why I'm always leery about giving people Narcan before they've been searched. Does that make sense? Has anyone been on an opiate toxicity yet?
Yes, I wasn't there, but Scott's call up in Flambeau, don't let the cops leave. As they gave him, what was it, like 24 milligrams, and they went to get the cops to get his name, they all left.
Yeah, we just tell them, I need you here until we have this position. We'll leave before you. If there's ever issue with it, please let me know. Number of patients, and I just put up this is actually the triage that I use more often than not, the 10-second triage. It's what we use on the SRT team I was on. There's multiple different methods. I know we have this smart cards in the ambulance. We're supposed to be, RTAC wants us to using the SALT triage method. And I'm not gonna get into triage tonight, because that's we can do multiple casualty incidents in a completely different session later on. But if we arrive, there's multiple patients, that may be something where you're doing like a 10-second triage and updating an ambulance with the plan. So the size of it, and this can be from a chest pain call to a house explosion to a bus rollover full of hemophilia. Every scene that location should get is capable of getting some kind of So provides incoming resources with a picture that allows for preparation. So I get paged for a lip assist, and I hear 3 people go on scene, and I don't hear anything on the radio. When I walk in and you guys are pumping on the chest, would have been nice to know that. So I would have grabbed a couple more pieces of equipment. Provides initial safety update. You know, hey, we got get paged for a motor vehicle accident, WNO, and it sure be nice if someone says, hey, there's power lines on fire. So now we know we gotta prioritize additional resources. Standard medical response, you know, just a quick update. You know, how critical the patient is, that it is stable. Patient's alert talk. That's huge. Patient's unresponsive for assisting with ventilation service or initiating CPR. And then we just know we don't need constant communication after that because they're going to be busy, but some type of update to the incoming ambulance. We've got a lot of different sets of equipment, so the more we know, the more we can get it. Fire scenes, I'm going to go over just some size ups real quick with you, with some different scenes and things that are good to communicate. So I just threw a couple of them up. Let's just say you're pulling up to that car accident. Anyone want to give me a quick size up on that? Your first one there, you got a radio.
We had a car off the road, overturned, significant damage, unsure of how many patients. No other power lines.
Yeah, so, I mean, that to me, I'm coming in the ambulance, I'm already thinking you probably want to get a helicopter launch. If it's just a single ambulance, I'm gonna call across, start coming this way. Let's get some additional resources, maybe put either at Imers Finding or at let's put a page out for 9-3 right away. Or the 2 reserve trucks. Okay, good. Snowmobile accident, let's just pretend you pull up and that guy's in the ditch. Anyone want to take any size up needed for that?
Male patient appears to be unconscious, off the road by X amount of feet or miles. What we're gonna need for resources as far as getting them out. We're gonna be able to bring them out on the slopes, or can we just take a longboard and send them up?
Yeah, and again, as usually, coming in the ambulance. I hear unconscious, launch me a helicopter, and we want to make sure fire's coming, and we need an landing house. Hey, anyone want to take, we get called for, fire alarm? People, or neighbor called, sees smoke coming out of the house, doesn't know if anyone's home. You pull up and that's what you see on the right.
Well, the single story residential, fire visible, it looks like on the Charlie Delta side, smoke throughout, there are vehicles in the driveway. We need to upgrade, we need extra resources.
Okay, and you know, are we expecting all first responders to know full fire size up? Absolutely not. But does the house look like it's on fire? Do you see anyone standing outside? Do you see vehicles I mean, what do vehicles in the driveways? Probably people home. You know, time of day. Factors in, you know, disregard the fire hose lines that are pulled out. But, you know, that's, you know, we hear that, and right away I'm thinking, okay, we probably might have a victim or multiple victims. And as a district, we've got firefighters to take care of. So we're gonna need to be that medical support for rehab, you know, for checking on the fire. So right away, I need another ambulance coming. If not, let's get a 3rd unit coming. You will, as, I guess, the chief of the district, you will never get in trouble for going resource heavy. I believe hit incidents with a sledgehammer right away. I want to overwhelm it with resources. I can always turn people around. Okay, I'm not worried about paying staff. I'm not going to be stingy about that. I'd rather have more resources and stage them until I need them. And staging, that may be time where, you know, we've got we'll just take that car accident the other night. So we've got 91921 scene. got 9-3, 9-4 coming, let's say, and I wasn't here, so I remember the details, and it may be, you know, I can show up on scene, I've got 2 patients for sure. I've got enough resources right now, but we don't know. That's where I may say, 9-3, I want you to stage at this intersection, meaning we've got enough resources right now, I might need you, you're on deck, I can pull you in quick if I need you, but by coming into the scene, it just kind of, anyone ever been to a scene where you're thinking, we could probably do without a couple of these trucks and vehicles here? It's kind of cluttering up, now I can't get ambulances in and out, things like that. So that's why we sometimes stage that way. Not where law enforcement or dispatch is staging us, but when we've got large scale incidents that we're staging units at certain locations, like a house fire. You know, we pull up to an ambulance on some of the roads up here. We pull in first, what's coming behind us? Bunch of big trucks, right? Now throw that in the winter when the roads are maybe half as wide as they usually are. What happens if we got a patient? You know how easy it is to move a fire truck once those lines are pulled and pumps are in here? So positioning that ambulance where we may have to, if for some reason we're gonna be first due, that we need to find a position back into a driveway, knowing those fire apparatus need to get in there so that if we do have a patient, we can load them and get out of there. And then the last one I threw in, we get called for, hey, Prescott, we got power lines down, smoke, and you pull up and you see that. You know, what are things that are important to communicate there?
Vehicle.
Trees on fire, fire spreading.
Yeah, we have a wildland fire, right? And, we don't need to get into, fuel type, plane length, and all that other fire size up, but we just know we have active fire. So if you're the EMS unit, we're gonna be committed for that. We're gonna have firefighters working. I tried to pick that, kind of looks a little bit like Alpha B somewhere.
Yeah.
Pick that picture. All right.
Quick question, Jason?
Yeah.
The size of, do you want us doing that every call? As first responders?
Not every call.
Significant changes?
Important is, it's, especially if you're there, incoming ambulance, it's awesome to hear, hey, they're alert and talking, or, lift assist, or patient unresponsive, those quick updates, but I always say if we just get in the habit of giving that quick little size up, even on your standard medical calls, that the more we do it, the more it just becomes practice, so when you pull up to the, oh crap, it's just second nature that we gotta get that communication disseminated. I don't know, Katie, you, as a responding medic, is there ever time you don't want information?
No, it's always good to know, because dispatch gets it wrong so many times, or it's third-party reports, or whatever the case may be, and we'll get, difficulty breathing, and they're unresponsive, or whatever the case may be, like Jason's talked about. But the other thing is, when we get there, normally we're grabbing the life pack, and we're grabbing probably at least one of our in bags, if we don't know what we're going to, so we can start doing whatever we need to. However, if you guys already have a set of vitals, and we can start moving to the ambulance, my favorite place to work on my patient is in the ambulance. I don't want to stay in their house. I don't want to stay where there's dogs and cats and cigarette smoke and who knows what in the house. And if I don't have to bring more equipment in than I have to, I don't want to. So if you tell me, patient's alert and oriented, working on a set of vitals, I'm now not going to bring my life pack in unless you have told me that I need a life pack immediately, because I'm going to get them loaded in my cot, or I can start calming them down, do a good 12 lead, make sure it's good and clean, do whatever I need to, and get that in the ambulance versus in the house. So it just saves some of the stuff we bring in if you guys tell us what you're doing or what you have. Or right away, if you know they have fallen, and Corky, the other night you said, bring in the vendor, like we're gonna need something. I knew ahead of time, like what we were gonna need because of what kind of the presentation was. That's helpful to us, because then we're just gonna bring that in rather than making multiple trips. So it just kind of, it removes some of our on-scene time.
Okay, so then we actually get to a patient, and it's kind of the old sick, not sick type, and that's really how I like to break it down. So my initial approach, I'm looking at, mental status, and they teach you the ABQ scale, which is, a lot of times people don't fit in that category, they're in between. So I'm looking at more, how are they interacting with me? Has anyone ever walked into that trouble breathing, and you're there and they're just focused up here, not looking at you, not interacting, that's impending respiratory failure. That they're not interacting with me, this is a critical patient. You know, if I come in and I say hi, and they say hi back, well, I've already checked a bunch of boxes. And okay, we got some time to work. The skin is huge, and of all the skin findings that make me the most nervous is diaphoresis. And that's basically, diaphoresis is sweating when they shouldn't be sweating. Now, what's causing that? Could be a list of things. And is it important for us to figure out which one it is right away? Absolutely not. We're just gonna prioritize getting our vital signs and start there with their, what we call hemodynamics. Is anything there causing the problem? And then, so the chief complaint, like, hey, why'd you call us here? Said my radio. I know, I'm going deaf, that's all right. So like, you know, the kind of the picture on the right, that pale diaphoretic, has anyone ever seen that? You know, I see that just walking in the door, I already know we gotta move. So, rapid physical exam. I try to do this every time, and obviously, you know, you gotta correlate with this, the patient. You know, so I get called for something, I walk in and they're talking and they're appropriate, I might modify this a little bit or slow down. But if they're truly in a critical patient who's either mental status is poor, if they're diaphoretic, I'm gonna move, and I'm gonna probably in a matter of about 45 seconds check these things. So if they're able to, I guess I gotta see, you have to start with bleeding. Do I see any obvious life-threatening bleeds? And if Bobby was on the ground, Bobby, would you be willing to lay on the ground for me and let me touch you? This is the only career that we can get away with this. Go in any position you want. So, blood sweep, that depending on the type of call, and if Bobby's got clothes, this is something that we would do in the tactical environment a lot, but it's very applicable to everyday EMS. So, we know hemorrhage, what's the matter?
No, well,
Okay, did it stop recording?
no, she was gonna move it.
Is that blood loss is like a preventable cause of death. So I want to try to find if Bobby's bleeding. So with my gloves, this is why I don't wear black gloves. Because I'm always going to kind of start at his head. You know, is he, I'm going to put my hands behind, feel, take him out. Take him out. Take him out. Look around the neck, look at him. In the armpits, look at him. In the armpit, look at him. If I just did this and then look and found blood, no, where is it, right? So that's why I touch, I look, I touch, I look, I touch, I look at him. Checking, if Bobby took a 9mm round to his armpit, there'd probably be no notice of blood on the outside. Until I got my hand in there and saw, and it'd be a little bit. That gunshot wounds, I know we fortunately don't see them up here very much. They can be very, very small entrances with no exits. And blood loss is, the problem is the blood's dumping in, not coming out. So that's what blood sweep is, that I may do that initially. And even if he doesn't appear to be breathing, that's gonna take me about 5 to 10 seconds to do a rapid blood sweep of what I can't see, even if it's just grabbing a shirt, taking a look quick, but I wanna see if he's bleeding at all, okay? Get up, buddy. Airway breathing, I'll quickly move into this. So, and this is the airway patent. And is he moving air? And I haven't really given you the quality of it yet, but if his airway is noisy at all, we need a suction. Clear it out. And if he's not responsive, we need to produce an airway for him. So, that can be as simple as positioning in a recovery position. It could be placement of a nasal airway. How many of you have placed a nasal airway? How many haven't yet? Does anybody want to? You can do it tonight.
Are you volunteering? Cause I'm
I've
not.
done it many times. But nasal airways, in fact, that's another, just some good airway practice, drop a nasal airways. That
No, I was just begging for it.
the unresponsive hypoglycemic diabetic, that's just snoring respirations, we put a nasal airway in. buys us time, and a lot of times just placement of the nasal airway, you'll see their O2 saturations jump from 80, mid-80s to 95 just by placing airway, no oxygen. So get an airway in. If the airway sounds noisy, if we got portable suction capabilities, suction it out. But then beyond that, I always go to the neck, and I'm sure you guys have heard JVD, right? Jugular vein distension. So jugular vein distension, like this picture, if somebody's laying flat, if I take a healthy guy laying flat on his back, you'll see some mild little neck vein distension. That's just normal. But especially if they're sitting up or they're up to the jawline like this is significant jugular vein distension. And what causes it?
Fluid backup.
Yeah. In a nutshell, it's telling me that that right ventricle of the heart isn't emptying blood effectively. Now, why isn't that? Could be a couple of things. Could be heart failure, could be collapsed lung, could be fluid in the sacral bone of the heart. It's just telling me that we've already got compromised cardiac function. So neck vein distension, although there's nothing I'm going to do to fix it right now, it's already thrown some flags up and it's prioritizing what I'm going to assess. With the stethoscope, I will really quick right and left. I just want to know is air moving in the right side and in the left side. I don't care if it's rales, rhonchi, normal. I just want to know, are we moving air? And especially when you look at like the tactical side, it's hemorrhage for preventable cause of death, number one. Number two is tension pneumothorax. So if they've got that collapsed lung, we want to try to identify that quickly so we can prioritize some interventions. Belly, pelvis, you know, I'm more concerned of like pelvic fractures, not hip dislocations, pelvic fractures. So I'll visualize the belly. I'm not palpating it, not looking at it, but I'm going to grab that pelvis and see if there's any stability. And I usually grab the iliac crest and I push out. It's a poor assessment. I've been on several pelvic fractures where the pelvis is completely stable, and then they get imaging and it's got a bunch of fractures. But within your pelvis, there's a lot of very important blood vessels. There's a lot of nerves. There's a lot of stuff that if you fracture a pelvic bone, it can create some very significant bleeding concerns, trauma. That a suspected pelvic fracture is a high priority trauma. What I don't really do is at that point look at the extremities, because unless it's a life-threatening bleed, there's nothing on the legs right now that are going to kill. If I did see blood squirting out of a leg when I first got there, what do? Tourniquet. Put a tourniquet on and we tighten it. When do we stop tightening? When the bleeding stops. Yep, that's pretty basic. Takes a couple seconds. You get the tourniquet on, stop. So before we jump into vital signs, I have to talk just a little bit about the circulatory system and shock. I know there's a lot of different definitions, but inadequate tissue perfusion, but really shock boils down to some component of the cardiovascular system is failed. And there's a couple components. There's the heart, which is the pump, the container, which is the blood vessels, and the fluid, the blood. Those three. And if we have one of those mechanisms damaged, anyone do work with hydraulics or ever blow a hydraulic line on something?
Yep.
Yeah, what happens?
Stops.
Yeah, it stops.
Stops.
Same thing with the body. When we lose the body's hydraulics, it is a closed system. So when we open that system, it doesn't work as effectively. So compensation, I know in school everybody talked about compensated shock, decompensated shock, irreversible shock. Remember those three big things? When you really get into the finer components of it, our goal is to really try to recognize that early shock before they're starting to manifest any signs and symptoms. So in them early stages of shock, a lot of our patients will actually be what we call hyperdynamic. Hyperdynamic, meaning their pulses will be mildly elevated, their blood pressures will be elevated to high, and meanwhile they're bleeding severely internally, or they're becoming septic. And this is because your body is beginning to put compensatory things in place to fix it. And we can see it all adjust through the cardiovascular system. So number one, how our body responds, vascular response. Our body's got pressure sensors that are sensing the pressure of that blood moving through. And when that pressure starts to drop, it tells our blood vessels to start to constrict, right? If I take a garden hose and I turn it on, water's flowing out of it, what happens when I constrict that outflow? Put my thumb over. I can increase that pressure, right? So that's what our body's doing. It's increasing those blood, or decreasing the diameter, constricting them to increase the outflow. It's also, as we progress, it will start shunting blood away. This is why we see pale skin, is that your body will just automatically start shutting down systems or blood flow to areas that aren't as necessary. Meaning your skin can go without blood a lot longer than your brain can. So your body will say, you know what, we're gonna shunt the blood from the skin, move it centrally where we need it. And that's where we start getting pale and modeling of the skin. Hormonal response, epinephrine or adrenaline is the biggest factor that your body senses that. Your adrenal glands start to secrete that epinephrine in your bloodstream. And that epinephrine then acts on the blood vessels to constrict them. It also gets to your heart and tells your heart to beat faster and harder. It's to squeeze harder. And that cardiac, all of this is done to improve that, what's called there at the bottom, that cardiac output. Now, we don't need to get into formulas. We're not looking at you to calculate this on patients. But your heart, or your body, to increase the amount of output your heart can provide, has to do one of two things. Either increase the heart rate or increase the stroke volume. And that stroke volume is how much blood is the heart squeezing out. So it will actually make that heart squeeze harder. That's what epinephrine does. So all these are mild compensatory mechanisms, but they can't last forever. Eventually, if whatever stressor or injury is happening, it will overwhelm the body's ability to compensate for it. And then we start to transition into decompensated shock. And this is where compensatory mechanisms fail. And a lot of people say in EMT class, well, this is, the heart rate goes up and the blood pressure goes down. Well, if we're seeing that, we're already moving into decompensated shock. And I'll use sepsis, for example, that I could very well get dispatched to a patient who fits all the criteria for early sepsis, and their blood pressure is 160/90, and I'm starting a liter of fluids. That we need to start volume resuscitating early because eventually they're just going to crash. So we're trying to get ahead of the game with some of the treatments that we give. So I just wanted to get that before we jump into our vital signs. So what I look at is a complete set of vital signs, which we expect on all patients in the ambulance. Unless they refuse, we should have at minimum heart rate, respiratory rate, blood pressure, and pulse oximetry. Those are the four primaries. And there's a couple other like glucometer, but those are the four that we expect on every patient. So you read a textbook, it's going to tell you your normal heart rate should be between 60 and 100 beats a minute. There's really no definition, or why do they say 100 is where you begin tachycardia or fast heart rates? They just had to pick a number. So from my experience, normal heart rates are more, and that's why I put 50 to 90. So you can have a pulse of 55, and I'm not concerned. You can have a pulse of 88. I'm not too concerned, but once your heart rate starts to get above 90, it really starts to make me think why. In fact, if anyone knows EKG rhythms, for me, the scariest EKG rhythm that I ever see is sinus tachycardia. It's not VTAC. VTAC, I know what to do. That's easy. We shock it. We know medicine we got to give for it. We see asystole. We know what we do for that. VFib, we know what we do for that. Sinus tac. Boy, this could be they're just nervous. They're in pain. Could be a pulmonary embolism, aortic aneurysm. The differential, if you will, is massive with sinus tachycardia. Most of my critical patients aren't excessively high or low heart rates. It's that subtle 110, 120. So how that's happening is your heart, just a little bit of anatomy. It's got these little pacemaker clusters within the heart tissue that those set the heart rate. This little one up here is called the sinoatrial node that If the impulse is originating from there, as it should, that's why we call them sinus rhythms. If that pacemaker site kind of has what we call an intrinsic rate of 60 to 100 beats a minute, meaning if we keep that heart perfused and oxygen and nutrients to it, that would just be 60 to 100 beats a minute, without any, what I would call neurohormonal stimulation. So obviously, if we squeeze a little epinephrine into it, it's gonna make it go up. If that fails, you have another pacemaker site here called the AV node, which is a backup, but it's a little slower. It's more 40 to 60 beats a minute. And if for some reason that fails, then all these little wires down here will take over, and that's much slower. Now that's now 40 or less. So as we lose pacemaker sites, it starts to slow the ability of the heart to work properly. The heart should be a regular rhythm with some minor variations. So meaning a pulse should be almost like a metric. When we start to get irregularities where it's kind of bouncing, that can indicate a couple different things. Sometimes you get some real subtle changes with heart rates. In fact, especially Renee, I would almost bet my paycheck you were in what's called a sinus arrhythmia, which means if you find your pulse right now, go ahead, do it. I want you to take a breath in, and then exhale.
What?
Feel your pulse.
Yeah.
Got it?
Yeah.
Now, while you're feeling your pulse, take a breath in,
Yeah, it did weird.
and then exhale. Do you feel your rate speed up a little bit, slow down? Okay.
Yeah.
So that's where you get a little irregularity, but it's, that's pretty minor for someone like Renee. The danger zone for me with heart rates is when we start to get below 40 or greater than 130. That's huge red flags for me, that not a lot of stable patients with heart rates less than 40 or more than 130, that there is something concerning wrong. I did add in their shock index for any AEMTs or medics in here. The shock index is a really good predictor of outcome associated, especially when we're looking at concerning hemorrhage. So what the shock index is your heart rate divided by your systolic blood pressure. So 0.5 to 0.7 is normal. As that number gets higher, the shock index goes up, it's more concerning for a patient. So for me, I'll use an example. If someone's pulse is 100 and their systolic blood pressure is 90, so if I divide 100 by 90, roughly what is that? 1 point something, right? So that's higher than 0.7. That tells me that patients are concerned, and depending on the call, high risk of bleeding, that we're gonna initiate things like TXA and some fluids and things like that. So just get to think that anytime your heart rate begins to exceed your systolic blood pressure, that is massively concerning. So the pulse rate, for me, if it's regular, feel it for 30 seconds, I multiply by 2. If it's irregular and kind of bouncing all over, then I might just feel it counted for a full minute. If you grab a wrist or you're grabbing a pulse and you're really having a hard time feeling it, it's threading, that maybe their blood pressure is coming down a little bit, sometimes you have to take a stethoscope and actually listen to the apical pulse in their chest. Some rhythms that we call like atrial fibrillation with fast response. So that's a real irregular heart rate, and sometimes those rates can get 140s, 160s, and especially if their blood pressure is a little low, it's very hard to feel it accurate. So I have to, listen to it if we don't have the ability to just throw them on a monitor. Respiratory rate, this is probably, to be honest, this is always the weakest part of EMS, but let's just talk about it briefly. There's I look at respirations as two components. What's the rate versus the volume? I can be breathing at 14 a minute, but very shallow. So I'm not bringing in enough volume. Without us being able to hook them up to certain measuring devices, we gotta look, do we see chest rise, chest fall, things like that. Rate should be for most adults 12 to about 20. You start to see rates greater than 20, I'm getting concerned, unless they're really worked up in a lot of pain. Again, you gotta look at what the, what's going on with the patient. Patterns, they've got a lot of patterns up here. I'm sure you've all heard about them. Kusmal, tachypnea, bradypnea, Biot's, ataxia. Respirations like pulse should be regular. That when you see irregular type respirations, the patient is, I don't think I've ever seen irregular respirations in a conscious patient. Does anybody? So there's your brainstem, okay? So, and this could be from bleeding, from pressure. Anytime we start to put pressure and affect your brainstem's ability to control the breathing, we see these irregular patterns. So with traumatic brain injuries, they're unresponsive and they've got these super irregular breathing patterns. That's, when you have irregular breathing, for the most part, it's a critical patient. And a bunch of red flags right there. Often subtle increases in respiratory rates, sometimes your first finding of compensation. And I put that stupid little formula on the bottom, and I'll just kind of describe it to you. Starting from the left, it's hydrogen combines with bicarbonate. So your body makes bicarb. It's to buffer out your pH of your body, right? So hydrogen begins to accumulate when people aren't breathing effectively. Your body secretes bicarbonate, combines with that. When those two combine, they turn into what's called carbonic acid. And then that carbonic acid essentially goes to our lungs and turns into carbon dioxide and water. So when we exhale, that's water. So even when you think about that concept, take your elderly person who's got a fever and he's breathing 24, 30 times a minute for like 14, 16 hours. You know how much fluid he can lose just from exhaling? And you take that little bit of vapor. So these are things that, we need to take into consideration. When we're early stages of sepsis or shock, our body isn't working effectively, and when it's not working effectively, we're creating more waste product, which our body's telling us we gotta start breathing it off. So we start to see these respiratory rates at 22, 24. They're not laboring to breathe, but when you count their respirations, and actually truly count them, either put a stethoscope on their chest, or a lot of times what I like to do is, Bobby, can I touch you again? You just sit there, it's okay, it's okay. There's a lot of times I'll come up, and when I'm checking a pulse, kind of a trick I do is I like to grab it, I'll kind of set my watch here, act like I'm counting, because if Bobby knows I'm watching him breathe, he's gonna change his breathing pattern. So I just act like I'm checking his pulse. So I'll do this, check his pulse for 30 seconds, and then for 30 seconds I'm counting his respirations. And then the trick is to remember those numbers multiplied by 2 correctly. But if Bobby's all of a sudden breathing at 28, 30, boom, a bunch of red flags are going up. Blood pressure. For me, initially, this is the most least concerning vital sign. If I can feel a pulse in the wrist, that tells me initially our pressure's okay right now. We'll get a blood pressure, but we're gonna practice some of this. I'm gonna be done talking here shortly, I promise you. But systolic versus diastolic, so systolic is that top number, and essentially what that's measuring is your left ventricular function, your left ventricle. It's typically, I hate to put a number on it, because if I took everybody's blood pressure in this room, I would bet you I would see probably a 50-point difference in systolic blood pressures. And everybody in here appears clinically stable, right? So blood pressure is relative to you. Now, a lot of people at home, I just asked, do you want your blood pressures? You'd be amazed by how often people check their blood pressures. And they'll tell you, well, it's usually this. Okay, well, it's not that right now. So, and diastolic is actually kind of a reflection of where your vasoconstriction is at. So, when does your coronary arteries fill with blood? During what point? When your heart squeezes or when it relaxes? Yeah, so when the heart relaxes, blood essentially sloshes down that aorta, the valves close, and it passively goes in the coronary arteries. So if my diastolic is 20, how effective do you think that coronary flow is? If my diastolic is 90 or 100, tell me I've got, there's some type of restriction in that blood flow. So that's how we correlate those numbers. Now, the 90, 80, 70 rule, man, I used to teach this, and I use this a lot. However, I started to find that, well, they got a radial pulse with blood pressure 70. So basically, has anyone ever heard of the 90, 80, 70 rule? So if you have a pulse in the wrist, the blood pressure, your systolic is at least 90. If you don't have pulses here, but you have them in the groin, your systolic's at least 80. And if you don't have them in the groin, but you got them in the carotid, it's at least 70. However, there's absolutely zero literature to support it. And so I would say, if you're, like I quit using it, I've had more patients that are not following the rules than I have that are following the rules. I just know if I have a pulse in the wrist that they probably have pretty good cardiac rhythm. So the blood pressure's palpated, auscultated, non-invasive. For me, I always prefer that first blood pressure to be auscultated. Blood pressure cuff, stethoscope, want to hear it. The non-invasive cuff, which is easy, which we grab from the monitor, put it on, push a button. First off, non-invasive cuffs are estimating the diastolic, estimating. So once I got a baseline to auscultated, then I'm, pretty good at putting on a non-invasive cuff. Palpated blood pressure, this is something where either we can't hear it or I'm trying to get, I want to know if they have enough blood pressure. This is usually something I'll do once. And I don't want to dig into that because we're all going to practice the different type of blood pressures tonight. Mean arterial pressure, or the MAP, is something that I use specifically, especially if I'm having to intervene therapy in fixing a blood pressure. And to get that number, it's 2 times the diastolic plus the systolic blood pressure, and then we divide it by 3. And that number should be 65 or better. The reason I like MAP is because everyone in here has a different blood pressure. What I can tell you is you all have a MAP of 65 or better. That when that MAP gets low, that's starting to become a critical patient. Now, when you use the non-invasive blood pressure, so you might see it come up 120/80, and then there's a little 2-digit number there. That's the estimated MAP that the machine's giving. So when you see that number, as long as that's 65 or better. Orthostatics. With orthostatic vital sign, and I forgot to mention earlier, if you ever come in and someone's pale, diaphoretic, and with weak pulses, what's one thing we can do? We walk in, someone's slumped over in a chair, they're not responding, they're pale, sweaty. I have a hard time finding a radial pulse on them. Lay them down. Yeah, a lot of times you get them flat, and in a minute or two, their blood pressure sometimes actually restores by itself. Hopefully. And monitor it, and if it doesn't, then we start to do our thing.
But isn't that like what happens with syncope?
What's it?
That's what happens with syncope.
Yep.
They go down, well then you get there and they're fine because they felt around and their blood pressure.
Yep. The orthostatic vital signs, I don't know if anyone's ever done this, it's kind of a decent reflection if, like volume status, so if they're dehydrated or low volume or some issue. So if we lay them flat, give their body about 2 minutes to kind of get used to laying flat and take their blood pressure and heart rate. And then we change their posture, so now sit them up. Again, give it about a minute or 2 for their body to stabilize, and we check their blood pressure and pulse again. And then if they're still doing okay, we can stand them up and do it. But anytime we change positions, if we have a heart rate increase and depending on the text, I usually go with 10 or more. So if their heart rate increases by 10 beats a minute by changing positions, or systolic blood pressure drop, I usually go 20. What do you use? 20 at any given time, that's what we call positive orthostatics. And they generally we need to hold them in a flat position and intervene somewhat to increase or maintain their blood pressure. Usually with IV, either fluids or medications. Pulse oximetry, kind of the last one. I'll go through this relatively quickly, but what we're measuring when we're doing a pulse ox is the hemoglobin molecule that's on your red blood cell, how much of it is saturated. That's it. That's all we're looking at. Saturated with what? Hopefully it's oxygen. But if someone's been in a high carbon monoxide area, carbon monoxide will saturate that hemoglobin as well. So we may have 100%, even though they need high flow oxygen. The pulse oximeters today have better technology but things that affected cold extremities, not good blood flow, so if their fingertips are blue, you're probably not going to get an accurate reading. Sometimes something as simple as just warming their hands up for a couple minutes help us get a more accurate reading. Or toes, we can put it on the toe or ear. I think we've got basically what we need to do is get some capillary blood to go through that light spectrum. The goal is 94% or better. I'm not going to get into this, but this is what's called the oxyhemoglobin curve. So over here, this is representing your oxygen saturation. You see it goes up to 100%, right? You can't have 101% or 140%, it's 0 or 100%. This down here is your called PaO2. Think of it, the oxygen that's floating in your blood. So normal PaO2 is about 80 to 100, but we can go, this graph can keep going. We can see PO2s of 500. Doesn't mean it's a good thing, it's actually a bad thing. But what we see up here is it's super, super flat, that as long as we're at 94% or greater, that correlates to PaO2 in good ranges. So just because they're 95%, we don't necessarily need to put them on oxygen. We still need to assess them to see if something's telling us we need to. And you need to anticipate pulse ox lag, and what that is where they are in this curve is actually about, when we're looking at the pulse ox, that's what that was a minute or two ago. So there is a little bit of delay to what their actual oxygen saturation is versus what we see. So if we put it on and we're seeing it going down, we need to step in and intervene before it gets to 90. Okay, because when we're seeing 94 and it's dropping, it's probably closer to 90. But once we get less than 90, you can see that curve drops very, very fast. SpCO, that's what we call carboxyhemoglobin, or we're looking at carbon monoxide. Generally, anything under 10% is okay. When we start to over 40%, we need to look at probably some specialized transport for the person. Those are those RAD 57s, and we should have one in each of our trucks. And kind of as we're, just 2 more slides, I promise. Point of care testing, glucose. 70 to 110 is typical normal. Just remember, newborns for the first 72 hours, anything above 40 is normal. Anytime we have a concern or a change in mental status, we should check glucose. That the glucose is almost vital sign. They don't have to be a diabetic. There's a lot of things that can increase it. Just having an infection, your blood sugar will go up. How many people have been to a diabetic that hasn't eaten in 3 days and they got a sugar of 300? And that's why, because they got an infection and sugars go up. We are checking lactates here, and we're kind of using that. I'm not going to dive into that tonight, but for us, that lactate is, it's not a diagnostic marker, but it increases our suspicion of things for like early sepsis. So you may see when the ambulance crew, we tap a finger or IV start, give me a glucose and give me a lactate. And the machines are very similar, and I know we're going to train them. And then I did have to throw in their temperature. We still check it, but I am yet to find without going to the special place. A truly good way to get an accurate temperature. No, we will not be practicing that tonight. Then kind of the last thing, if the ambulance isn't there, is these, what I call scale assessments, and the two big ones are our stroke scale and our pain assessment. So stroke assessment, there's a couple different ones out there. Be Fast is kind of the popular one. Balance. What's E again?
Eyes.
Eyes, face, arm, speech. Cincinnati, all kind of looking at the same thing. VAN is vision, aphasia, neglect. So everyone typically thinks of a stroke as a rapid loss of one side of their body. But some stroke presentations can be very subtle. I think we're seeing a big turn into when in doubt, we just pull the stroke alert card and go that way, unless we can rule it out. So stroke TIA, to me, they're both highly concerning, and really there's not much on-scene care we can do other than make sure we check the glucose, because low blood sugar can mimic a stroke. And one of the biggest things that we can try to work on is when is the last known well time. So specifically, when was the last time you've seen them with normal function? Might have been yesterday, might have been 10 minutes ago, but that number is huge. And if we can try to get that number, that pays dividends in the long run. And then of course your OPQRST, which hopefully everybody's pretty comfortable with, but your onset, what were you doing when the pain started? You know, and a lot of times we think chest pain, you know, well, I was throwing hay bales for 6 hours versus I was sitting down watching TV. You know, one's a little bit more concerned. Provocation, what makes it worse? Quality, you just ask the person to describe the pain in their terms. Try not to give leading questions. Radiation, point to where the pain hurts the most, and then does it move from there? Severity on a scale from 1 to 10, and time, how long have we been having? These are pretty important questions, especially when we're looking at what we suspect cardiac pain, but we can use it for abdominal pain anytime. So, with that, I've talked way too much. We will stop, and we're gonna, especially tonight, just kind of practice on, if we can find a partner, and we're just gonna work on getting a set of vitals, taking blood pressures, and Katie, anything, especially on blood pressure assessment, that you'd like to add, or?
First, I just want to throw out, like, if you guys are, within like this first 5 minutes, if we ever get on scene, know from the paramedic point of view, one of the first things we look at and do really quickly is sick versus not sick. If all of a sudden you see me come in and I'm not talking to you a whole lot and I'm doing stuff, I'm going, this is sick and we need to move quickly. If I'm there and I'm letting you guys do stuff, I'm going, we're not sick and I want you guys to have every opportunity to keep doing your skills and getting your assessments. Give me those vitals, then I'm gonna let you guys do all of that all the time. And I think most of our medics are pretty set that way, if it's kind of that critical thing we see right away. The other thing that's really helpful in those first couple minutes that we get on scene, and I know that this has been a big change, is that we carry a lot of equipment that maybe you guys aren't as familiar with. And so if there is ever a time that we are working and you wanna come in and go through the rigs, and we will show you the different equipment that we carry that maybe you're not familiar with the terms. Because if we have an airway situation and you're extra hands for us and we're saying, hey, where's the bougie? Hand me an ET tube, hand me the MAC 3, right? And some of those things you're going, I don't even know what that is or where that is. By all means, we will walk you through our bags and things in the ambulances so that way you know what all of those things are and where to find those. So just know that that's an opportunity for you guys that we're all happy to do. But as far as taking blood pressures, know that if you're not getting a blood pressure on one side, you can always check the other side or switch to the other side. That's one trick. And I always ask my patients, is there any reason I can't take a blood pressure on one side or the other? You'll encounter a lot of individuals who've had mastectomies or cancer survivors, or maybe they have PICC lines in their arms, and all of a sudden you're going to put a blood, and they're like, you can't do that. And you're like, oh, why? So I always try to ask that question first. Is there any reason I can't do a blood pressure on one side or the other? Do you have a preference, why I would do one? I had one lady who had a really bad rotator injury and she just didn't like her arm manipulated, caused her pain. So I would just ask that question when you're taking them.
And for those watching online, the safe word for this session is licorice. Licorice.